And thank you for joining the CFHA monthly webinar. This month we are pleased to bring you Quality Improvement in Integrated Care, a Practical Introduction. Our speaker today is Dr. Joe Grasso. Joe is a postdoc research fellow with the VA and a VA quality scholar with the San Francisco VA Medical Center. At this point, I'd like to pass it to Dr. Grasso, who will be speaking on quality improvement. Thanks, Joe.
Sure. All right. I'm very excited to present this topic today. If you're anything like me, or at least how I was a couple of years ago, you'd heard the term quality improvement. You knew that it was something important, at least on the minds of a lot of healthcare administrators and clinic leadership, but you don't have a really strong sense of what QI is. And I'm here to say there's no shame in that. That is a common perspective, and this presentation will hopefully help you with getting a really nice foundational knowledge of what QI is, why it's important, and how it can be applied to your local setting. So today we're going to do an overview of QI specific to integrated care, and we'll talk a little bit about how QI can be applied in an integrated care setting and solve particular problems that are relevant to behavioral health consultants in particular. So just to get started, there we go, for your learning objectives. My goal for you at the end of this presentation is to be able to explain what QI is and how it applies to integrated care. We'll be talking about lean concepts, and so it'd be great if you were able to describe what those concepts are and what their use is in healthcare QI. Together we'll craft a SMART aim statement, and if any of you BHCs out there are familiar with SMART goals, then this will be pretty easy and familiar. And then at the end, to be able to create an outline of a Plan, Do, Study, Act, or PDSA cycle for your own QI project. And the PDSA cycle is kind of the foundation or the basis for most QI work. So we'll be hammering that home throughout the presentation. All right, so first question, what does quality even mean? You know, there's a lot of talk in healthcare about improving quality of care, and you probably have some vague sense of what that means, but when it comes down to specifics, that can be a little more difficult. So the Institute of Medicine defines quality as the degree to which healthcare services or health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Now, that doesn't really help us a ton, but it gives us the sense that quality has to do with improving healthcare services such that you're getting desired outcomes and you're practicing at the top of your license, and you're also practicing with informed knowledge about best practices for your field. But in terms of specifics, we're a little light. So when it comes to quality improvement, you might expect that the definition is equally vague. And so here, from this book, The Fundamentals of Healthcare Improvement, the definition of QI is the combined and unceasing efforts of everyone. So that means healthcare professionals, patients, families, researchers, payers, planners, educators, all of us, our effort to make the changes that will lead to better outcomes, better system performance, and better professional development. So a little more specific, and what I like about this definition is it also emphasizes the importance of improving professional development outcomes. So this is about improving the learning process for us as well. So we'll talk a little bit more about that, but to get more concrete, to get more down to the essence of why you specifically should care about QI, let's just get really practical. Well, because the systems that we operate in are expecting it. A lot of healthcare systems are developing entire programs or offices around doing quality improvement. because they've seen that quality improvement can lead to reduced costs for their healthcare system. Now, there's lots of reasons to do QI, but if you're a healthcare administrator, cost containment is a big one. So your medical centers often expect it because payment will be tied to it. With the Affordable Care Act, there's an increased focus on making healthcare services more cost-effective and for making them more efficient. And so the ACA includes many provisions that are conducive to QI or make QI a particularly important skill set. Because administrators can be persuaded by it. Let's say you've started a clinical program, and this is a clinical program that requires resources from your clinic or your medical center. If you're able to demonstrate through a small project or a small pilot QI project that your work is saving the clinic or the medical center money, it's making things more time efficient, it's increasing access in some way, then you're going to really be ahead of the game in terms of being able to persuade your administrators to come on board. And because it can result in improved quality of care. And I bold that because, that really is the most important part. There are a lot of important practical reasons to do QI related to efficiency and money, but at the end of the day, you want to make sure that your patients have the best quality care. And that is something that QI can do by improving the efficiency of care delivered, and that addresses access problems, making sure that care is more effective. We know that a lot of well-intentioned clinicians are not necessarily adhering to evidence-based protocols. So that's where QI can be helpful in increasing effectiveness of care for patients. And then also in improving patient satisfaction. And if you think about the triple aim, this spirit of QI is all about helping providers, helping healthcare teams, helping healthcare administrators better meet the triple aim. And at the end of the day, those are all things that improve quality of care. So here's kind of a case study or story to bring this to life. If you're not on board yet, hopefully after this story, you're more convinced. So I want to take you to the White River Junction VA. This is a VA clinic that serves 13,000 primary care patients in a rural setting. And for years, I'm sure many of us have seen this before, there was mental health staffing attrition and increased mental health referrals. So there was this sense that staffing wasn't meeting demand, and it reached the point that by 2003, the average mental health evaluation time was 6 weeks. So if a patient was referred from primary care for a mental health evaluation, it was on average taking 6 weeks, and then the follow-up no-show rate was upwards of 40%. So this was a very inefficient system. And everyone had the same obvious solution. If you're like me, your immediate thought is hire more staff. And the VA, being the VA, said, no, we're not going to do that. First, we want to know what are other potential solutions to this problem. And so that led to the formation of a team that was designed specifically to come up with alternative solutions through the use of QI. So this team's goal, which they developed a SMART goal for, which we'll talk about soon, so take note of their goal. It was to reduce veteran wait time for mental health intake to less than 14 days upon referral from primary care and to ensure appropriate follow-up mental health treatment as designated by a mental health clinician within 6 months. So very, very specific and time-bound. And so this team developed this goal and then immediately went into their Plan, Do, Study, Act cycle, which we'll talk about soon. And so they planned a first round of improvements, and that first round of improvements was a failure. And we're going to talk about why that's okay, and it's even expected. And it was only after a second round of improvements was initiated that they took a look at the literature and conducted some focus groups. And so the result of that process was a complete clinic overhaul and the birth of a new integrated care model. So in that first round of improvement, the team was focused on some solutions that we're all familiar with: increase access to groups, make reminder calls to patients, and that really didn't move the needle. What ended up making the biggest change is in the second round, when the team conducted some focus groups and found that most primary care providers found that their patients really just needed triage. They were encountering patients with minor mental health problems who needed to see a clinician immediately for an assessment, perhaps, but they could wait for follow-up treatment and may not even need much in the way of follow-up treatment. That, combined with the review of the literature, led to this team developing a new clinic, the primary care or the primary mental health care clinic, which was open to provide access for brief problem-focused evaluation and treatment. And the treatment that followed was short-term within the primary mental health clinic, unless it was a complex case, and only then was it referred to specialty care. So this is a model which to us seems pretty standard by this point, but at the time was pretty revolutionary. And it resulted in some dramatic change. From Q2 to Q4, the number of patients referred to the mental health service dropped 74%. So there was a 74% decrease in referral out to specialty care. The no-show rate to specialty care declined by 2/3. The average wait time for intake declined from 33 days to 19 minutes, because you have that same-day access with the primary mental health clinic. And then there was a 50% increase in referrals to the clinic, so the actual number of referrals went way up, but there was a 74% decrease in referrals out to specialty mental health, meaning that most patients were effectively managed in this brief triage clinic, which really validates what we do in our clinics as BHCs. So this is an example of QI at work and doing something that actually resulted in a change of healthcare service delivery for a lot of VA clinics. Now, we can think smaller scale, things that are more relevant to your clinic. There are plenty of examples of how QI is relevant to your integrated care setting. QI can help with problems related to patient wait time, promoting more appropriate BHC referrals, enhancing access to our services, improving adherence to clinic protocol or evidence-based protocols, reducing inefficiencies in the warm handoff process, and facilitating more effective care coordination. And that last piece we see come up a lot in primary care clinics, making sure that care coordination and communication between services is more effective. These are all aspects of clinic operations that QI can be very effective in addressing and improving. So if you're not alone, if you're thinking to yourself, this sounds a lot like research, and I got into this to provide clinical care. I did not get into this to conduct research. Well, QI is not research. You'll have to trust me on this. It differs in some very important ways. So if you're worried about things like research design and statistics, fear not. QI is different in that, first of all, the purpose is different. Research is conducted for the purpose of developing generalizable knowledge. And QI, on the other hand, is not about disseminating knowledge in peer-reviewed literature. It's about solving a clinical problem. It's about improving clinic operations. And so if you're conducting QI, you're concerned with quick practical outcomes. In terms of sampling, very different. You're not doing a randomized clinical trial in QI. Your sample is usually the patients who come through your clinic, or the providers in your clinic, or the team members in your clinic. It's a convenient sample because that's the sample that matters, the sample that's either working in your clinic or being served by your clinic. The process is very different. QI is all about short, rapid cycles. And so the initial round of QI for a project could be anywhere from a week to 6 weeks, maybe 2 months, and rarely in QI are you conducting these long-term projects the way you would in research, because again, you're focused on quick, practical results that will result in an improvement of some clinic operation. And then lastly, interventions are different. In QI, if you find after 2 weeks or 3 weeks of conducting your QI project that nothing is changing after you've initiated some type of intervention, you can scrap it. You can move on to the next intervention. And that's going to be a really important part of QI that we'll talk about, the need to be evaluating the effectiveness of your intervention in real time so that you don't hang on to it for too long. Once you realize that it's not working for you, maybe that's the signal that it's time to start your next round of improvements. Very different from research, where you might be conducting a study for months and months. You don't analyze the data until the very end, and then you write up the results, whatever those may be. QI is not like that. It's a lot more practical, and it tends to be really appealing to clinicians because it gives them a sense that what they're doing has very real practice-based implications. So earlier you might have heard me talk about lean. So lean is kind of a collection of concepts that's focused on streamlining, making processes and workflow more structured and more efficient. So if you're engaged in lean thinking, your goals are to map out the current process of your problem in detail before you do anything else. So this is really important because, all of us want to jump to solutions. We may start a QI project with some very good solutions in mind, but I promise you it's worthwhile to first break down what the current process is, because we might think that we know what the current process is, but I almost guarantee you that it's a lot more complicated with a lot more variability than you might think. And that's important because you want to find out where the points of breakdown are in your process. Where is it in this process that we can intervene and make it better? And then once we find that, we can develop measures to assess the problem as we try something new, identify the areas of waste, and waste usually for us is in the form of time. And for other types of providers in healthcare, waste could be about resources like tongue depressors. We don't have those kinds of resources to deal with. So for us, usually the waste comes in the form of time waste. And then we apply the 5 S's. And so the 5 S's stand for sort, straighten, shine and scrub, standardize, and sustain. And so again, for providers that have physical resources that they're dealing with, these first 3 are more important. For us, the last 2 are most important. Standardize, and so for us that means standardizing a process. If we come up with a way to enhance access to BHCs or a way to enhance care coordination between BHCs and primary care team members, then we would want to standardize that process to make sure that it's structured in some way and that process lives on after the project. And that piece is also about sustaining it, making sure that whatever improvements we make are sustained over time. And so we'll be talking a lot about that as well. So as I mentioned before, the PDSA cycle is kind of the foundation of QI. And there's many different approaches, but underlining most approaches is some form of the Plan, Do, Study, Act cycle, which it's exactly like it sounds. You plan out what it is that you'd like to do to improve the current process. Then you actually do it. You collect data so that you can study the effects of your intervention. And then based on what you find from those results, you act. And act can mean either institutionalizing your change and making sure that it sticks if it was effective and it's sustained, or act can mean that intervention didn't work that well, we're going to scrap it, we're going to do something completely new. And all of this process first begins with developing some objectives for your PDSA cycle. So before you have some objectives, you need to know what the problem is and who's involved. So that first entails determining what the problem is with the status quo and who's involved in that problematic process. And so this isn't a blame game. It's about developing a QI team that can best address these issues. And the people best positioned to address these issues are the ones who are most involved. Those are your stakeholders. And so stakeholders often include medical providers, allied health professionals like us, administrative staff, clinic leadership, but also patients. Depending on what the problem is, you may be very well served to include a patient on a QI project so that they can provide perspective on what the experience is like on their end. And once you've identified these key figures, you want to contact them, form a team, and you may not be able to include all key figures on a team, but you want to do your best to include as many as possible. And buy-in from your administration is really important because this is going to take some time. So you're going to need to take some time away from clinic to meet as a team and go through your PDSA cycle process. So the way to get buy-in from administrators is to tell them we're doing a project that could save this clinic time or save this clinic money or increase access or make things more efficient. And I understand it's a hard sell for a lot of folks to get time away from clinic, time away from seeing patients in order to do something like this. But if you can explain to an administrator that you might be potentially saving this clinic money or time or making things more efficient, chances are you'll get at least some buy-in. You'll get your foot in the door. So once you've identified your problem and you have your team, the team is going to come together to develop an aim statement. What is it that this team is purposed with doing? And so that can come, or that should come, in the form of a SMART aim statement. And if you're a DHC, you're probably familiar with SMART goals. Same concept: specific, measurable, attainable, relevant, and time-bound. So no matter what your QI project, even if you think it's something simple, even if you think that the solutions are clear, you still want a SMART aim statement because you want to make sure that you're successful. And the only way to know that you're successful is to have specific, measurable goals in mind so that you can measure your outcomes and that you have a project that is realistic and relevant to your clinic and and this project can be conducted within a reasonable amount of time. And it's just as problematic of an issue to have an overly ambitious QI project and to not give yourself enough time to do it. So here's an example of a SMART aim. Well, since we're doing this virtually, normally I would poll the audience to ask them if this is a SMART aim, but since we're virtual, I'll just give it away and tell you it is indeed a SMART aim. The example is to reduce the wait time for patients in our primary care clinic to be seen by a BHC following a warm handoff from 30 minutes to 5 minutes by December 2013. Yes, this is indeed a SMART aim. It's specific. You know exactly the action that's being targeted. It's measurable. We can measure it in terms of time or number of minutes. It's attainable. This seems like a goal that's plausible for a clinic, especially if they have a BHC system already in place. It's certainly relevant to the clinic operations, and it's time-based. You're going to be achieving this aim ideally by December 2013. All right, so as I mentioned earlier, it's important to first, before starting your improvement process, it's important to first describe the current process. So before you can improve anything, you need a deep understanding of what is actually happening with the status quo. So that means, what are we doing now? How is it that we do it? What are the major steps involved in this process? Who's everyone involved? What do they do specifically throughout this process? What's done well and what could be done better? And again, you may have a lot of assumptions about what the current process is and what the problems are, but it really helps to map things out. And so this is an example of a process map. And it's conference season, so there's lots of people heading out for conference travel. So I like this example. This is the map for what the process looks like for attending a conference. So you think, okay, I request approval to attend the conference, I travel to it, I go, the end. That's a simple process. But if you break it down a bit more, it's more complicated, right? You start, you request approval to attend the conference, you may or may not get approval. If you do get approval, then you have to register, you complete the registration form, you fax it in, you plan your travel, maybe you get confirmation, and then you have to arrange payment, then you attend the conference. So the process is more complicated than originally thought, but if you go even further with it, you see it's even more complex, because if your organization is anything like mine, you request approval to attend the conference, you send that to a supervisor, maybe they approve it, then that supervisor sends it to a manager, and maybe they approve it, and then it's sent to a department head for approval, and so on and so on. So notice how this process, when we break it down, we get so detailed that the end point isn't even attending the conference. It's getting approval to attend the conference. That's because the process is always more complex and always more detailed than we initially give it credit for. And it's important to know all of these details, because look at all of the places along the way where things can go wrong. There are so many steps between wanting to go to the conference and actually attending that if there's a breakdown in any of these spots, then it could derail the whole process, and that might be the place where intervention is needed. So just a quirky little example to show you, it's always helpful to map the process first in detail so you can pinpoint exactly where the breakdowns are and exactly where your intervention is most needed. So we're going to use this case example throughout the discussion of the PDSA cycle. And it is a case example of the primary care provider to BHC handoff. And so I'm sure all of you are familiar with the handoff process. For our case, it's happening at an urban VA integrated care clinic that identified an inefficient handoff process. So everyone involved was noticing that sometimes the BHCs are not available at the time of the handoff, that sometimes patients are kept waiting, and so they often have to leave before the BHC can see them, and that there's minimal collaboration between the primary care provider and the BHC due to time constraints. So the PCP is dropping the patient off, and that's really the extent of the interaction between the PCP and the BHC. So, and everyone recognizing that this was not ideal, there was a QI team formed of stakeholders that included primary care providers, nurses, behavioral health consultants, and together they examined the current process and initiated a PDSA cycle. So after examining the process, they started the planning stage. And in the planning stage, we're concerned about what is it that we're trying to accomplish. So we have our SMART aim. That should be out of the way. Then we're concerned about how we'll know that the change is an improvement. So we want to know exactly how we're measuring change and what changes can we make that will lead to improvement. So here you're starting to finally think about what are the potential solutions here. You've mapped your process, hopefully you know where some of the breakdowns are, and that allows you to start thinking about what are some changes we could make to solve these problems. And so you're starting to plan out those potential solutions. So in our example, the team found that different providers were conducting handoffs in varying manners. So some providers were contacting BHCs by instant messenger, some were bringing them by physically, some were having the nurse conduct the handoff. So that was leading to a lot of variability in the process. And variability often creates a lot of waste. So when you're trying to think about what are the areas for improvement, look for waste. Be on the lookout for waste in the form of variability. So when people are doing things significantly different in terms of a handoff process or a clinic procedure or adherence to a protocol, that variability leads to waste, time waste usually. So in this example, the BHCs had partial open access, but they were not informing the primary care providers of scheduled follow-up appointments. So BHCs were scheduling follow-ups, which is perfectly appropriate, but the PCPs had little idea of which BHCs were available and when these follow-up appointments were happening, so they didn't know which BHC to bring their patients to. And then in addition, visit length was significantly varied. The team found that some BHCs on average were seeing their patients for 22 minutes, which is certainly appropriate, and some BHCs were seeing their patients on average for 44 minutes, and that's significantly different. And if you have some BHCs who are seeing their patients on average for 44 minutes a session, that can certainly affect access. So together, the team came up with their aim to reduce wait time for patients in the clinic to be seen by a BHC following warm handoff from 30 minutes to 5 minutes by December 2013. So that example looks familiar, right? And the measure was going to be wait time, as noted, and start. How long is a patient having to wait from the moment that a primary care provider and the start of the actual visit? And the initial plan, was to include BHCs in a pre-clinic huddle to identify potential handoff patients and coordinate care. So this clinic had been conducting pre-clinic team meetings that did not include BHCs. And so at these meetings, primary care teams would discuss patients coming in for the day, what those patients' needs might be, but BHCs were not included. The thought was that if we include BHCs in these meetings, maybe we can better plan ahead so that for patients that we identify in the morning as probably needing a BHC handoff. So we'll talk a little bit about how that worked out in just a second. So for the do piece, or P and now D, you want to focus on who's going to carry out what part. And so you'll need a team leader or facilitator to oversee the process and ensure everyone's on the same page, and delegate who's going to collect data. Ideally, you want everyone to collect data, or as many people as possible to collect data. So in this case, you have data being collected in the form of wait time, the time between a handoff and the start of the BHC visit, but you also want to collect qualitative data, because you might have a really effective intervention, but what if people hate doing it? Or what if it serves as a major burden to people involved? So you want to collect qualitative data as well that assesses how did this affect the workflow? What was the satisfaction with this intervention? What were some of the things that made this intervention hard to implement? That qualitative data will help you understand whether your intervention is sustainable or not. So everyone's feedback matters in a QI project. So once it's determined who's the team lead and who's delegating and who's collecting data, you want to execute the plan. And so you make the change identified and you run it over a specified period of time. And the period of time, you don't want it to run too long, right? You should be able to get a sense of if your intervention is effective within 2 to 6 weeks. And you want to specify not only the length of time for your QI project, but exactly who's doing what, in what capacity, over what period of time, where. So again, trying to get as specific as possible about what everyone's roles are in the project and in what setting and in what context and in what period of time they're fulfilling those roles. For the data collection piece, you want to gather measurements to assess change, and you want to do that in real time, and you want to have as much data as possible, so you want to collect data on a daily basis and perhaps be analyzing it as frequently as every week. And we'll talk about that in the study portion, but it's important to collect as much data as possible, document unexpected and unintended events, and that's where it's important to have the qualitative data. So someone that's taking note of what it was like to actually implement this intervention, what some of the unanticipated challenges were, and what helps this intervention to work well. So in our example, the lead psychologist served as a team leader, and the team jointly designed a protocol for BHC participation in these pre-clinic huddles. So this team of the primary care provider, the LVN, the RN, your clerk, they were all meeting at the beginning of the clinic to talk about patients later in the day. The team developed a protocol for how the BHC would participate in these meetings. So the BHC was supposed to come in and hear the list of patients coming in for the day and chime in on who might be most appropriate for a BHC referral, and then provide their availability for the day and hopefully match that up with when the patient would be coming in. The PCPs and BHCs jointly collected wait time data and submitted spreadsheets on a weekly basis. And so every week was a tabulation of wait times for every patient handoff that week. And at the end of each week, that data would be analyzed. We'll talk more about that process in a moment. Qualitative data was also collected not only in terms of how easy or difficult was it to implement this intervention, but also what was the change in collaborative activities. You have this huddle meeting happening that now the BHCs are included on. How does that affect the way the BHCs and the PCPs collaborate with each other? I won't spoil it for you, but it certainly had an effect. And they designated this, the QI study period as 6 weeks. So they were going to conduct this test of change for 6 weeks, and at that point they would determine, is this something that they keep, or do they scrap the huddle idea and come up with a new solution because it doesn't work. So 6-week study period. So now we're in the study section. We've planned it, we've carried it out, now we're studying the change. And you have your target change that you're measuring, and for us it's wait time. And we're also trying to assess for unintended consequences or unexpected events, again using that qualitative data that we solicit from our stakeholders. there's different ways to analyze your quantitative data. And so for us, we use, or this example used a run chart. And so a run chart simply is a chart that measures processes over time. So you have in this bottom left corner an example of a run chart for a clinic that's measuring the % of diabetes patients with completed depression screenings. And you can see each line represents a different clinic. And I'm guessing right around November 2014, there was some kind of intervention because you can see a dramatic shift in the % of patients with completed screening. So the run chart is really helpful for measuring changes in processes, and I could do a whole series on run charts alone. But if you do a Google search, you can find a template for run charts that will literally just allow you to input data into a spreadsheet template, and it will spit out a run chart for you. On the right is an example of a Pareto chart, and the Pareto chart is focused on measuring which factors most significantly contribute to a problem. And you may have heard of the Pareto rule, which is that 80% of a problem is created by only 20% of the number of factors. So here, this is a nice example of what's contributing to a patient satisfaction or patient dissatisfaction. And here you can see that 70% of the issues are created by those first 3 problems. And so the other 3 problems are contributing pretty minimally. So that type of chart may be helpful if you're more focused on figuring out what the contributors to your problem are. And maybe you're at an earlier stage of your QI process. So for our example, we collected the daily average wait time for our patients. And so remember, we were collecting data on a weekly basis. And so we took the average amount of time that a patient waited each day that week, and we put that on a run chart. And we could see over time that the average daily wait time was going down. In fact, within the first week, we saw that the average daily wait time was reduced by 7 minutes from the beginning of the week to the end of the week. And then when we measured week to week, from week 1 to week 6, the average daily wait time was down by 12 minutes, was down to 12 minutes. So quite a significant decrease. And then remember, we've been collecting that qualitative feedback from our stakeholders as well. And that data was showing high satisfaction among BHCs and PCPs, and that there was more collaboration and more shared treatment planning happening as a result of BHCs being in that morning huddle meeting. So lots of indicators of success. So now that we've studied it and we have the data and we have some idea of what our outcomes are, we can act. We can decide, do we want to maintain this change because it's worked out really well for us? Do we want to modify this change in some way? So maybe it's worked out reasonably well, but there's something we need to do to make the huddle more effective. We could modify it. Or do we decide, you know what, this worked, but it didn't work well enough. Let's scrap it and do something different. So that could mean a different change altogether. So this process is all about incorporating the information that we learned from all of the steps in the cycle thus far, and then deciding whether to move forward or start all over again. And that would involve planning the next change and making another prediction. So by the time you're at this stage, you're already thinking ahead. Either we're going to sustain this or we're going to scrap it, and it's time to go back to planning. In this example, there was the significant wait time improvement, and there was more collaboration, so it was pretty successful, but we still hadn't reached our aim. So remember, we wanted to reduce our wait time below 12 minutes. And so even though 12 minutes was a significant improvement, we're still not fully at our goal. So instead of scrapping the huddle idea altogether, this team decided we should just try and augment it with another solution. So a new PDSA cycle was initiated, and this time that solution targeted a reduction in session length among BHCs. So the baseline average for a BHC visit was 31 minutes, which meant that there were some BHCs who were seeing patients longer than 30 minutes, which of course is not ideal. You want a BHC visit to be 20 to 30 minutes on average, or pretty uniformly. So an effort was made to standardize the huddle process and make it sustainable, because that part works and we like the huddle, but we're also starting this new PDSA cycle to further reduce wait time and hopefully standardize a new process of making BHC visits shorter. So in thinking about a PDSA cycle for your own clinic, you want to ask yourself some questions in the planning stage. Who's going to be involved in this project? And who's going to lead this project? And often the person who's best positioned to lead is the person who knows the process the best. So in our case, who knew the most about the handoff process? Well, the psychologist or the BHC did in this case, because they had dealt with different PCPs, so they knew about the variability in how the handoffs happened. They knew their schedule the best, so they knew why there were these challenges to full open access in their schedule, and they knew their colleagues relatively well. They knew some of the other challenges faced by BHCs. So usually when you're thinking about who's going to lead your project, you want to think about who knows this process the best. Sometimes it actually comes down to who has the best temperament. So it may not always be about who has the most knowledge. It may be about who is the most patient or even-keeled or has the best leadership qualities. So that's for your team to decide. You want to figure out how can waste be eliminated. Again, going back to this idea of how can this process be more efficient. So first, breaking down the process. What are all of the steps happening along the way in this process? Where are the areas where it could be better? And identifying where it could be better by looking for waste, usually in the form of variability. So where are there points in the process where people are doing things wildly different from each other, or where are there areas in the process where time is being wasted? How will you measure progress? So being very specific, is this a measure of time? Is it a measure of number of patients? Is it a measure of number of completed screenings? You want to have some kind of specific quantifiable measure. What interventions might you do? So what interventions are going to be most effective at targeting this process? And it's okay to think ahead. So, you may come up with 3 potential interventions. Well, maybe rank order them from most promising to least promising. And if your most promising doesn't work out after all, then maybe it's time to try the next one. How often are you collecting and analyzing data? Ideally, again, as frequently as possible. You want to be measuring as close to real time as you can, because the more data you have and the more frequent the measurement, the more that you can track those small shifts in change over time. And ideally, everyone is responsible for this process. So everyone is providing some form of data collection. And if it's not the quantitative data collection, then it's hopefully the qualitative data collection. What was it like for me as I helped implement this change? What did I observe about the workflow? What did I observe about patient satisfaction? Because we want to, again, make sure that whatever intervention it is that you're testing is sustainable. And if everyone hates doing this intervention, that's not sustainable, no matter how effective it may be. And then lastly, if your intervention didn't work, how might you decide what's next to try? And so maybe you already had a list of ideas in advance and you just start working through that list, or maybe you learned something really important by doing your project that informs what your solution should be. So if this huddle situation hadn't have worked out and we scrapped it, maybe instead of thinking about interventions that have to do with coordinating schedules and enhancing collaboration, we learned those types of solutions aren't really effective. We need to come up with something more radical, like structuring BHC's schedules, or making BHCs more accountable for shorter sessions. You learn a lot through doing your first PDSA cycle, and that knowledge should inform future cycles so that they build on each other. So troubleshooting, if you conduct a PDSA cycle and you go through this process and find people may hate your protocol or your checklist. A lot of QI projects will default to a checklist solution. Well, we need to standardize the process. Maybe we just create a checklist and make sure that everyone is sticking to the checklist. If people hate using your checklist or refuse, it's not effective. So make sure that people are using the tools that you provide them in whatever your planned solution is. Is your data collection rapid enough? Again, not wanting to hang on to an intervention for too long because you want to be able to launch into your next PDSA cycle if your intervention is not really effective. Are you making work harder or easier? That's where your qualitative feedback comes into play. Your stakeholders will hopefully be giving you helpful feedback on that process. Are the benefits observable to users? Let's say you conduct your QI project and the numbers bear it out. Your data tells you this is an effective intervention, but is it observable? Does it feel effective to people involved? That matters too. You want whatever your intervention is to yield some kind of observable benefit to your stakeholders. And lastly, are the changes sustainable? Is this something that's sustainable not only in terms of the willingness of people involved to keep it up, but also if it requires some kind of shift in resources, is this something that your administration is going to support? So that's where getting buy-in from your administrators becomes really important. All right, so just some key takeaways as we wrap up. Prediction followed by reflection leads to learning. So at the beginning of this process, you make some predictions about what could be helpful, then you do it, and then you reflect upon what these changes resulted in, and that leads to learning for your next process. So by carrying out this project and studying it and getting quantitative and qualitative feedback along the way, you learn a lot about A, your current process, and B, what solutions are most appropriate, but also you learn a lot about the willingness of people involved to participate in an improvement effort. And so that reflection will tell you a lot about what direction you need to go in for your next round, should you need to do a second or third or fourth PDSA cycle. Know the ins and outs of your process. So this, I could do a whole series on process mapping. I think process mapping is perhaps the most important piece of all of this. Knowing how to describe in detail your process from beginning to end and all of the little steps along the way and who's involved in every step so that you can solve the areas of breakdown and do that with some precision. Use small tests of change directed at key steps in the process. So that's just kind of describing what we were talking about with targeting your intervention to the very specific points of process and efficiency. Using feasible changes to be implemented quickly and measured over a short time frame. So again, you don't want to jump to a clinic overhaul, right? First, you want to try some smaller solutions that may make more sense, and then you learn from that process about what may be needed next. You don't always need to jump to reinventing the wheel. And then lastly, multiple change cycles are usually required. There's no shame in failing in your first try. It's a learning process. It's an iterative process, and you take what you learned and your next round. Just really quickly, here's some resources that I find really helpful. IHI.org is the Institute on Healthcare Improvement, and they have a ton of resources on how to do QI. They have templates for creating checklists and worksheets that will help you with data collection or developing a protocol. Really helpful and all free materials. HRSA, or the Health Resources and Services Administration, has a QI toolkit, again with a lot of free materials that you can use in your QI project and some nice planning worksheets to help you plan out your PDSA cycle in detail. So if you like some structured hand-holding, those QI tools are really helpful. The VA Quality Enhancement Research Initiative, or VA Query, has a website with a method selection tool that I really like. So you give it some information about the type of project you're trying to do, and it helps you select what methods you should use to collect data and analyze your data. So that's a really neat interactive tool. And then if you're looking for a book because you've been so inspired by this presentation and you want to learn everything about QI, then I recommend The Fundamentals of Healthcare Improvement, A Guide to Improving Your Patient's Care, written by some very smart folks for the Joint Commission. So that's it. Thank you so much for watching this presentation, and hopefully it inspired some interest and passion for conducting QI in your own local setting.
Thank you, Dr. Grasso, for an outstanding presentation. Quality improvement initiatives in all integrated clinics are essential in helping us improve patient care, access, and outcomes. And thank you to the audience for joining this webinar. On behalf of the CFHA Research and Evaluation Committee, we'd like you to tune into our website where all of these webinars will be archived, and you can see both past research and evaluation webinars as well as webinars on a variety of other topics. Thank you for joining us today.